All right, we're going to talk about chronic illness, death and dying. All goes as part of Chapter 12, the caring for the special needs child. They've included also premature infants in this section, as they are very high special needs kids. So that's going to be part of this chapter as well. So if you see infant questions on the exam, they will be in relation to failure to thrive, prematurity. It's not a developmental thing. I'm not regressing, okay? So those type of questions may be on this exam. All right, definition of children with special needs. Those who have or are at risk for a chronic physical, developmental, behavioral, or emotional condition beyond needs generally required by children. These guys are pretty high maintenance. So lots of teaching, lots of emotional support, lots of technological support, lots of medicinal support, health care, collaboration in the team. So lots of people with their hands on these kids. There are varying degrees of special needs. I mean, you can have a chronic, a patient with a chronic illness like cystic fibrosis or even asthma. Asthma can be considered a chronic illness where they need little to no interventions, or you can have a totally technology-dependent, ventilated special needs child that is, takes a lot of a full-time parent there to take care of them. All right, some resources that they may need: medication, equipment, PT, OT, speech therapy. Those are all part of the team with these kids. Financial assistance, they may need social work help applying for grants or programs. There are lots of programs out there to assist these families, but the process of application is arduous, so they may need some help going through that, being guided through that process. Some impact on the family. Now there's a whole section that expands on this information right here in the text, and I'll show you exactly where that is. It would be good to know that information. Development, things that delay the development. Okay, infant, they may not develop that trust, the trust versus mistrust, because they're in the hospital, they're around so many different caregivers. Toddler, they may never progress to that autonomous stage because they either are, dependent, can't walk, or in the hospital a lot. Preschoolers may have a difficulty getting that initiative. They may, again, they probably will be a little bit delayed if they're a chronic child that requires a lot of hospitalization, just because that's the nature of the beast. School age, of course, school presents a problem with these chronic kids because they miss a lot of school. A lot of times they have to attend school at the hospitals, or, if they're hospitalized for long periods of time. The school districts are really good about either reaching out to them and providing them with the work, or providing them with an opportunity to actually go to school at the facility. And then adolescents. You can imagine the toll it takes on adolescents. They have that stigma that they have some chronic illness where they're different than everybody else. So a big impact chronic illness is on adolescents. Some impact on the family. These families are more likely to be, you may see more divorce in these families, lots of conflict, because it's so stressful on the family to have a child with special needs. So lots of support needed there. Anger, sadness, guilt, frustration, all of that kind of comes with it. Siblings are affected a great deal with a child with chronic illness. You can imagine how much time the special needs child takes up from mom and dad. Siblings can feel like they're left out. So good support for the siblings is important. Okay, and then we talked about financial burdens. Parents often can't work, or have to stay home and take care of the child, so that can be an issue. Sleep is affected, housing, medical care, technical care, equipment, just getting a rest from, taking care of a dependent child every day is important to family. Some transition times, sometimes that they may need some extra special support. Definitely at the initial diagnosis, lots of teaching, lots of support, lots of referring, all of that is really a lot to deal with at the beginning. Increased symptoms if their illness becomes worse. When they go to a new setting, say you've got a NICU baby that's been in the NICU for 6 months. They move out to home, that's a big transition time, so lots of support needed for the families there. Developmental change when they become teenagers, when they start walking, those are all big changes in the lives of these kids. If they have siblings or if the parent gets married, those can be some high stress times as well. Vulnerable child syndrome. These are some things that let's talk about vulnerable child syndrome. Kind of causes the parent to be a little overprotective. And so these are some things that might put the child at risk, and they're pretty common sense. A preterm baby, some sort of congenital anomaly syndrome, some sort of handicapping condition, whether it's an accident or, a head injury or anything like that. Or if the 5-month-old falls out of the crib and hits his head and has a head injury. Sorry, I just had to throw that in there. If they're a poor feeder, if they're cranky, or if they have reflux, or if they're failure to thrive, those can increase the risk as well. All right, this would be a good slide to remember. Family involvement in these kids is very important because you're going to teach the parents to take care of these children outside the hospital. That's our goal, is to get them home and get the parents as their main caregiver. Families are constant. They, cultural differences may exist that you need to be aware of. They need access to everything that they can get their hands on. You got to know their strengths. You got to know their weaknesses so that you can help them through the weaknesses. Okay? Be respectful. And the parents need to understand that it's their ultimate responsibility. They're not going to have a nurse 24/7. Well, they might, but typically they're not going to have a nurse 24/7 there to be with their child. So they are going to have to be responsible for the care. Case managers are really important people on the team, the interdisciplinary team for these children. They kind of manage all the resources and all the referrals, and if your chronic child doesn't have a medical home, that's a big problem because you have lots of people trying to direct things every which way, and you need one coordinator of care. Screening, ongoing assessment of the kids. They a lot of times have home health nurses that go out periodically and do an assessment, maybe do some procedures, wound care, or whatever. So that's really important to kind of keep up on the condition of the child. Excuse me. If they have equipment, wheelchairs, hospital beds, that has to be, care of those has to be taught to the parents, and who to call if they break down, etc. All right, and definitely the referral for resources. Social work has to be involved in these kids' lives too. All right, so if we're going to send our patient home, say they're ventilated, they have a trach, they're going to go home, lots and lots of transition teaching, okay? That's the majority of the getting ready to go home. The children are probably medically fine, but the parents have to learn all of this equipment and, learn how to care for it, learn when to bring them back to the hospital. So those are all things that you do from the get-go. They say plan for discharge on admission, and that's the truth of these kids. Care coordination, Sometimes they do a home visit to make sure that, say that they have a wheelchair, to make sure that it's compatible, that it's ADA compliant, and just the child is able to get around in the home. Provide ongoing follow-up for preemies. They are usually followed by some sort of clinic for premature. I think, what's it called at Parkland? I can't remember what it's called at Dallas Children's, I'm sorry. But, they have a whole clinic for premature infants, and they're followed there for a while. And assessing growth and development. Okay, here comes your milestones back. You need to know what they're supposed to be doing, when they're supposed to be doing it. Okay, you also need to be able to figure out prematurity and gestational age and corrected age. So that's important to remember as well. Some long-term risk of the preemie. You might have some cognitive delays, ADD, some learning disabilities, some behavioral issues. Chronic lung disease is probably the biggest one. Unless they have a brain bleed or something when they're little, because they are more vulnerable to that. Chronic lung disease, if their lungs aren't mature when they're born, 28, 29 weeker, then they can have a chronic pulmonary road ahead of them. All right, some failure to thrive causes. Okay, I want you to remember that failure to thrive can either be organic or inorganic. Okay, organic means that something's wrong in the body that's causing this child not to absorb nutrients, calories. Okay, of these listed here, inability to suck or swallow correctly, if they have a cleft lip, cleft palate, that can contribute. Malabsorption, of course. Cystic fibrosis, you can't absorb your fat. If they have short gut syndrome, they can't absorb their nutrients. So those can both cause failure to thrive. Diarrhea, vomiting acutely. Acutely, they usually don't cause failure to thrive, but if they're chronic problems like reflux, then they could possibly cause failure to thrive. Now, the inadequate prep of food and disrupted relationships with maternal figure, poor bonding with mom, is what that means. Those are inorganic. Neglect is also inorganic, and what that means is there's no medical cause. Okay, it's a knowledge deficit or it's done on purpose. So if it is a knowledge deficit, we have to correct that. If it is a neglect issue, or a mom is trying to stretch the formula issue, then that needs to be approached a little differently. So just be aware of the situation. Some resources, and we've talked about this already, educational opportunities for the parents and for the child. Kid needs to know what's going on with him and what to expect. Financial resources are always something that's needed, either insurance coverage or programs to get medications or programs to get equipment. Respite care, giving the parents a break from taking care of the kids. And then some complementary therapies, horseback riding, which is called hippotherapy, which is kind of odd. They might use some herbal medications or nutritional supplements. So those are all resources for kids with special needs as well. This talks about music and massage and pet therapy. We have pet therapy dogs at Cooks that come around and visit with the kids. They're very helpful. You might see some herbal medicine and homeopathic medicine. Don't judge. You need to know, though, how they interact with medications, the pharmaceutical medications that the patients are on as well. And you need to be able to teach, speak to that to the parents. If there's some sort of weird interaction, the parents need to know about that. Some educational resources. We talked a little bit about school. ECI. All right, ECI is a great thing. ECI, if you have a premature infant or an infant with a chronic disease that's very young, they need a referral to ECI, early childhood intervention. And these nurses, they're nurses, they come out and they evaluate the child for therapy. So they may they may determine that this patient needs physical therapy or this patient needs speech therapy. And they set all that up. And the therapists come out to the home. It's a free service. It's done through the government. I believe MHMR now oversees that. We used to have community placements in ECI, but the travel presented a problem. Students had to drive their own cars way out in the country. So we stopped placing students with them. However, great place for nurses to be. And then they have to provide school or education to kids in the school age years, through 21 actually. And it's usually provided by the local school system. Fort Worth ISD has a classroom at Cook Children's, and I'm sure Dallas ISD has something with Dallas. TCH in Houston, they're a big place, and so I assume that they contract with the Houston ISD, and they have a education program as well. Now, even the smaller, like out in the outskirts, if a child is in the hospital, the school district is responsible for providing them with education. All right, transition planning. So you've got an adolescent, and there's a couple different things, different transitions we're going to talk about. If they're an adolescent and they're aging out of the pediatric system, that's a transition. That's a transition to adult care. Also transition from hospital to home, okay? Both of those require care coordination, okay? Community resources. If you've got a chronic child going off to college, that's a big, huge transition. So that's all part of transition planning. Acknowledgement of the changing roles of the patient, of the family, of the healthcare professionals. A lot of times the physicians change. They only take care of pediatric patients up until age 21. So, the physician may change. Fostering independence is important, and the importance of a medical home. You've got to have somebody to coordinate this stuff. All right, this talks a little bit specifically about adolescent health transition, and you start this pretty early in adolescence. They've already started it with Tyler a couple years ago. He's 16, and so the Cystic Fibrosis Center is already, he does his own meds, and they ask him the questions when we come in. I'm just the driver, or I was just the driver. He can probably drive himself now, but so that transition starts pretty early. Age 17, they're thinking about, okay, co-pays, how do I get my medication, how do I get a refill. Parents can keep children on their insurance up to age 26, but they need to start looking at that for future. Can I get on my own policy? Pre-existing conditions, those need to be a part of the information that they get from these policies. 18, they have all rights at that point, okay? College, they need to know, how to take care of themselves, when to go do the checkup, or when do they go to their 3-month follow-up, what to do if they get sick, where to go. So transition in adolescence is a big deal. And then this is just what we talked about. Danger signs, they need to know when they're sick. They need to make sure that they go to the doctor when they're supposed to, and they need to make sure that they stay compliant with their treatment. All right, so the sad part of this chapter talks about end of life. Now, there are pediatric hospice nurses, God bless them, that's what they love to do, okay? I don't know that I could do it. I did adult oncology, and we had hospice patients, and that was hard enough. So some things that you might see related to end of life, limitations of care. They can be very specific on their care plan, okay? What they don't want and what they want. DNRs, do not resuscitates, those can be very, very personalized as well. So a little more than just, we don't code this person. They may be, we code them, but we use medications but we don't shock. So it's very, very individualized. Allow natural death. That's one that I haven't heard. We still use the DNR, I believe. All right, so if you have a trauma or if you have a patient that's not a chronic child that passes away, organ donation could be a possibility. Now, pediatric organs are in very high demand and very low supply. So this is a touchy subject. This conversation should not happen when the child is pronounced dead. Okay, it should be a separate. It should be a separate conversation. Chaplain does it at a lot of places. Nurses can be advocates for organ donation, and I don't mean advocates. I mean relayer of the information. Okay. Is your child an organ donor? Would you like your child to be an organ donor? This is the process, okay? Kind of just give some hard facts there. All expenses are paid for by the recipient's family. Need to make sure that the family knows that you won't be able to tell on the outside that their organs have been donated. And then you've always got the cultural and spiritual beliefs that you have to consider and respect. And I'm not even going to go, written consent obviously is necessary. Okay, palliative care. Palliative care could mean a lot of different things. It could mean at the end of life. It could mean our chronic illness is not getting better. Our cancer is back. So it can mean a lot of different things. Palliative care has a couple of goals. If the child is old enough to be aware of what's going on and be participant in his care, then you need to do that. You need to respect their goals, their preferences, their choices, and the families. Sometimes those differ. So that's a touchy situation. Use your resources. Use your chaplain. Use your pain management people. Okay. The focus of palliative care: pain control, comfort, emotional support to the parents and to the child. Okay, nutrition, whatever they want to eat. At this point, if they don't want to eat, and they're a DNR, then you don't push that. Okay, if they want ice cream for breakfast, then you get them ice cream for breakfast. All right, so let's go over to the chapter. All right, whoops, I'm at the very end. Sorry about that. Let me get back up to the beginning. Apologize. This should have not happened. Okay, medically fragile child. It's just another term for special needs or one with chronic illness. The paragraph that I was talking about that describes the effect on infant, toddler, school age, preschool, adolescents is right here. Really important to read through this paragraph here, this section. Okay. Each one of these sections, this chapter does not have a care plan. So the nursing interventions are kind of interspersed between the content here. So here are the Healthy People 2020 goal or objectives. Effects on the parents, as you can imagine, stresses parents really a lot. Financially, emotionally, physically. So know that you're going to be, or the nurse is going to be a big support person, needs to be a big support person for the family. Okay. Stressors of daily living, and here again are the transition periods that can add some stress to that. Most of the time it's mom that's taking care of the child, but occasionally it's dad. And a lot of times it's both. They take turns. So feel out their strengths, act on those, and know their limitations. Siblings, we talked about how siblings are affected. Family involvement, okay, and this is that slide that was up there that I said that might be important to remember. Please do that. Home is where they need to be, okay, so preparing the home before discharge, and again, this is sometimes a home visit, a home consult is done before the child goes home, but these are definitely things that need to be relayed to the parent, to the family. Early discharge planning. Start discharge on admission. Okay, this section talks about the technology-dependent child, and just know that they need to know where they get the equipment, who takes care of the equipment, and how to work the equipment. Okay, I think we've addressed the whole coordinator of care. You have to have a person that coordinates all of the team members. So case manager, social worker, you know, whoever that is in the patient situation needs to be the boss of everything. Also, physicians. Now, physicians, you'll probably have multiple specialties that work with these kids. Sometimes that can present a challenge. They don't always talk. They're not always in the same system. And they're not always on the same electronic medical record. Hopefully they are, but it doesn't always happen. So we need to make sure that coordinator of care needs to make sure that the right hand knows what the left hand is doing. Medications, this is a biggie, especially in the adult world. You go to a couple of different doctors and you have the same medication, so you need to do a medication reconciliation with these kids as well. Alright, so this whole section talks about preemies. Alright, these are some things that you might see later on with premature infants. Okay, chronic lung disease, we talked about that being a big one. Growth retardation, poor feeding, failure to thrive, reflux, hearing screens, retinopathy. Those are all things that premature infants are prone to have. So assessment for those is very, very important. Also assessment of their motor skills, their fine motor skills, their gross motor skills. Got to keep up on that. Okay. Nursing interventions, like I said, this chapter doesn't have a care plan, so here's some nursing interventions for the broad spectrum of kids with special health care needs. Okay, there's a little baby feeding through a feeding tube. Well child care to the preemie. Again, these kids are followed through the clinic, or usually through a clinic. So immunizations are important. RSV prophylaxis sometimes is important depending on when they're born. So make sure that you are aware of that. If they're born in August and they're premature, they're going to need RSV prophylaxis for the winter. Okay, and that stuff's not cheap. Alright, growth and development of the preemie infant. This talks about corrected age, what milestones to assess for, very important. Okay. Feeding disorders, we talked about failure to thrive. These are some interventions if you've got a child in the hospital that you suspect failure to thrive. You need to kind of pay attention to these. Observe their interactions. Is it a knowledge deficit or is it a bonding issue? And you need to address whatever you find out. Alright, again, there's the Healthy People 2020 objectives. Talked about respite care. Hippotherapy, horseback riding. It's very popular in chronic needs kids. They have places all over the Metroplex that have horseback riding therapy for a multitude of different disorders, okay? Even for autism or for brain injury. You know, it seems to calm these kids. So, very interesting. Transition, we talked about transition, a couple slides on that. I think the information on the slides is exactly what you need to know about adolescent transition to adult care. Okay, we talked about DNR, parents having an an obligation to keep their kids safe, but they also need to make sure that, consents, assents, those type of things are in place. Okay. Involving the dying child in the decision-making process if it's appropriate. Don't necessarily, you'll have to fill out the situation and see if it's appropriate, assess the dynamic in the family, and then share what you think is appropriate. We talked about organ donation. We talked about palliative care, hospice care. Nursing management focuses on a couple of different things: pain and coping. Okay, so pain control is paramount in chronic or the dying child. We want to keep them comfortable, just like with adults. Nutrition, like I said, if they want ice cream for breakfast, give them ice cream for breakfast. If something causes nausea, the smell of something, get it out of the room. Just, whatever they want at that point. And here's some resources for families of the dying child. There's also a lot of resources through, like the Ronald McDonald House. They have a sibling program for, kids that have their brother or sister pass away. Lots of community resources out there, but you have to know where they are. Okay. All right, that's it. This was kind of a short chapter. Again, there's no care plan, but there are some key concepts at the end that might be important to know.